Hi, my name is Dr. Ruth Zafar. Welcome to my short course on oral caries, modern day diagnostic tools and treatment options. Let's begin with the educational objectives. By the end of this course, you will be able to define oral caries, describe the current equipment used to detect carious lesions, identify the limitations of visual, explorer, radiograph, and dyes for caries identification, and list different diagnostic tools using light. Discuss advantages of diagnostic tools using light over traditional diagnostic methods. Implement the steps and use the material to access carious lesions in a minimally invasive manner in clinical setup. Identify the different burr types and their use in minimally invasive caries management. Determine how to restore a tooth using a variety of composite bonding agents and resins. There are 3 steps for understanding the occult lesions. First, we have to understand the phenomena, where it comes from, and what it means to us. Secondly, we need proper diagnostics, and for that, we can use visual, explorer, radiograph, dye, and light. And finally, once we've discovered these lesions, we need to treat them in a minimally invasive manner, for which we can use specialized burrs, flowable, and paste composites. So let's discuss the phenomena of occult caries. So here in this picture, you can see an occlusal view of a premolar. The enamel seems intact. There is no discoloration. In fact, no abnormality can be seen. But once the enamel was removed or de-roofed, what lied underneath was horrific, a large carious lesion. So let's understand why this happens. What is an occult carious lesion? It is a carious lesion that occurs beneath a seemingly intact enamel surface. Look at the tooth. Some areas here seem questionable. These areas, but the enamel is intact. It is commonly found beneath the pits and fissures of posterior teeth. So you could see once the enamel was removed or de-roofed, a large carious lesion was detected. So, do you think it is a newly discovered phenomena? If we look at the literature, occult caries was first documented in 1868 by Knapp in American Dental Association. Then, in 1880, Black brought it down. Then, 1922 and 1924. This is an original article by G.V. Black in which he writes that pit and fissure cavities occur in surface of the teeth that are habitually clean, except as the imperfections of the enamel. Pits and fissures afford places for the lodgement and fermentation of debris, which causes the beginning of decay. This is a paragraph taken from Black's article. Here I've underlined the important part of this passage where he writes that the dentine is burrowed out beneath the enamel in such a manner that the diameter of the cavity just within is larger than the opening. So 113 years later, Chan wrote, caries is regularly found beneath a seemingly intact enamel surface. Frequently, the diagnosis of occlusal caries is less than straightforward. So basically, Black was very specific in his findings, and 113 years later, Chan substantiated it. So it's not a new thing, and it's something still going on today. If we take a look at the diagnostic materials and methods, we have visual, explorer, radiograph, dye, and light. And first and foremost, regardless of whatever diagnostic method we use, a diagnostic aid should show a very low level of false positives to avoid unnecessary treatment. And that's really what we want. We don't want to be so aggressive about these that we do not want to treat anything that looks suspicious. We want to know whether caries is truly present or not. So let's discuss the first part of it, visual. Is the visual exam valid for diagnosing occult caries? Here, in this picture, the surface looks healthy and intact. However, there is the presence of decalcification and subsurface discoloration. Occult caries can be present in the most normal-looking clinical cases. Is the visual exam valid for diagnosing occult cavities? If we take a look at the literature, Olvera et al. Said that the visual examination with or without diagnostic adjuncts can identify cavitated lesions efficiently, but not non-cavitated. And Asaf et al. Said it is difficult to determine whether a lesion is active or arrested by simply looking at it. I think we can all agree to these statements. So, what about diagnosis by explorer? Can we find hidden carious lesion using an explorer? Or the real question should be, is the explorer a valid tool for diagnosing hidden caries? So, in an article by Penning et al., he found out that probing is unreliable in finding fissure caries. So, the next question is, why is probing unreliable in finding fissure caries? Reason number one is that the non-cavitated tooth, even though the enamel is decalcified, it is still hard enough to prevent the explorer from sticking. And secondly, the pits and fissures have holes smaller than a probe can penetrate. So if probe can't penetrate a lesion, you won't get a sticking effect and thus cannot detect the lesion. Talking about facts, an explorer out of the box or a new explorer can enter an area no smaller than 30 to 40 microns. So 30 to 40 microns is the smallest area explorers can penetrate. Anything smaller, the explorer cannot get through. And here is what G.V. Black wrote about examination with an explorer, which is pretty much the only tool they had in his days. He wrote, "A sharp explorer should be used with some pressure, and if a very slight pull is required to remove it, the pit should be marked for restoration, even if there are no signs of decay." Now, I know his concept occurs of prevention, but here we are talking specifically about non-cavitated lesions. And when he focused on this, he understood the problem enough that he said even though the slightest pull means restoration. How reliable is an explorer? In an article by Al-Sahbani, he said that the reliability of carious lesion diagnosis by sharp explorer compared to diagnosis of carious lesion by histological cross-section was 25%. That means that an explorer to diagnose these lesions is reliable only 25% of the times. So if you're only using an explorer to locate non-cavitated lesions, you can only find 1 out of every 4 lesions that exist. So moving on to our next possible method of diagnosis, the real question is radiograph an effective tool to detect carious lesions, non-cavitated carious lesions? There is often no X-ray evidence because of the thick enamel surrounding these lesions. Radiographs do not detect all occlusal lesions. Enamel thickness can be deceptive. So enamel is so thick around these lesions that the X-rays cannot penetrate through them and detect the underlying carious lesions. So if we take a look at this X-ray, we cannot see any superficial or deep caries. Why is that? Rock and Kidd in British Dental Journal said, decay is difficult to detect in radiographs unless larger than 2 millimeters to 3 millimeters deep into the dentine, or 1/3 the buccolingual distance. So yes, enamel has to be this thin to allow the radiograph to show the carious lesion within it. This X-ray is of this particular molar. The molar seems absolutely fine, no discoloration, no abnormality, the enamel is intact, and there was no sign of carious lesion even in the radiograph. But once it was removed or de-roofed, a large carious lesion was detected underneath the enamel. Here is a case of a non-cavitated carious lesion. The patient is a 26-year-old male with a history of occasional cold sensitivity. And this is the lesion we discovered after de-roofing, which is pretty much why he had cold sensitivity. So it wasn't very obvious visually. Explorer did not detect it, and no discoveries were made on the radiograph. So pretty much sums up what diagnostic tools we had 20 years ago were not enough to detect non-cavitated carious lesions. Okay, what about using carious detection dyes to diagnose non-cavitated lesions? How does carious detection work? According to Fusuyama, there exist two distinct layers of soft dentine. The outer soft dentine is infected, unmineralized with irreversibly denatured collagen, non-vital and non-sensitive. The inner soft dentine is uninfected, remineralized with reversibly denatured collagen. Optimally, the outer soft dentine should be removed while the maximum inner non-infected dentine is preserved. The real question is caries detection dye reliable? In an article by Boston Yep et al., they said in two separate studies it was found that when the level of infection of dye-stained and unstained dentine at the dento-enamel junction was measured at the completion of cavity preparation, it was discovered that not all dye-stainable dentine was infected, meaning that healthy dentine was stained with dye as well. And further, in their study, it was stated that 52% of the completed cavities showed stain in some part of the dento-enamel junction. But subsequent microbiological analysis of dye-stained and non-stained sites resulted in the recovery of very light levels of infection, with no difference between sites. Such bacterial levels were considered clinically insignificant. It has also been demonstrated that absence of stain does not ensure elimination of bacteria. It is now established that these dyes do not stain bacteria, but instead stain the organic matrix of less mineralized dentine. So staining the truth or staining the what we think is carious lesion, the caries and healthy dentine are both stained. So dye has become increasingly unreliable, and now the routine use of these dyes without an understanding of their distinct limitation will result in excessive removal of totally sound tooth structure and increased likelihood of mechanical pulp exposure.